I'd like to welcome everybody to our 8th AVE with our Alumni Virtual Event sponsored by BASH with our doctors, pharmacists, and administrators. And looking forward to tonight. Before we get started, though, I'd like to start off with a prayer. In the name of the Father, the Son, and the Holy Spirit, amen. So I'd like to pray for the Belen community, the alumni, the parents, staff, teachers, everyone. I'd like to pray for all of those that are inflicted now with COVID and have suffered with this pandemic that we've been through now. It's going to be a year almost, and I'd like to pray for all those that have perished with that. And I also like to thank God for the opportunity to do this as well and share with our community. So in Jesus' name we pray, amen. In the name of the Father, the Son, the Holy Spirit, amen. So I'd like to welcome you again to this AVE. We have a great panel today. We had a little bit of technical difficulties, and we're trying to work that out. That's why we're a little bit late. But anyway, so what we're going to do is I'll be your moderator, Carlos Bravo, class of '86, and I'll be introducing the panelists, have them say a little bit about themselves, and then we're going to go ahead and get started with in regards to COVID updates, information on vaccines, information on distribution. These are all alums that have volunteered their time to do this for us, and I'm very proud of that fact, and looking forward to what they had to say. So I'd like to first introduce Javier Gutierrez from the class of 2000. He is a senior director of physician services at Jackson Health Systems. So Javi, welcome. If you can say hello to everybody, say a little bit about yourself, it'd be great.
Good evening, everyone. My name, as Carlos mentioned, Javier Gutierrez. I am class of 2000 at Belen. From an educational background, I attended law school. I practiced law for a couple of years. Quickly realized that the area of law I was in wasn't very interesting. I was fortunate enough to make a jump towards healthcare on the legal side, but as my career progressed, it sort of veered towards the operational side. And under my current role as a senior, I've had several roles at the Jackson Health System. Under my current role at the Jackson Health System, the Jackson Medical Group, which are all the employed physicians of the Jackson Health System, all the employed physicians and providers, and all the outpatient practices that the Jackson Health System has. Some of my interests are obviously operations, business development, relationship building, because that's really what healthcare is about. So I have been involved with the vaccine distribution at the Jackson Health System, so looking forward to talking to all of you about it.
All right. Thank you, Javi. Appreciate that. Thank you for that great introduction. Next, I'd like to introduce a veteran to our AVEs for his third appearance, Dr. Eduardo Martinez DeBouchet from the class of 1990. Wanted to say a little about himself. In previous AVEs, he hasn't been able to. He's talked a lot, which is fantastic, has a lot of things to say, and we love how he delivers. So say a little about yourself, big guy. Go ahead.
All right. So class of 90, like you said, I'm currently serving as a medical director for telehealth services for the Baptist Health System. We have 10 hospitals from West Palm down to the Keys, and I'm also the director for our EICU, so we do telecritical care across our system hospitals, and I serve as chair of system-wide critical care for the health system. In that role, do a bunch of different things, and you'll hear a little bit about it through there. I've had a few iterations, also, like Javi said, and I think that's what gets us here. Is ever changing, ever growing, and in getting to a place where God could be.
All right. Well, thank you, Ed, and looking forward to what you have to say tonight. And next, we're going to introduce Willie Braceras from the class of '88. He was having a little difficulty coming in, but I just been told, my producer just told me that he's in. And he's a pharmacist from the class of 1988, Willie Braceras, on audio only, but he's here. So your voice, my friend, go ahead.
Thank you, Carlos. Sorry about the delay. So my name is Willie Braceras, pharmacist. Been a pharmacist for 27 years. I've been with Baptist for 11 years and at Baptist Maine for like 7 years. My background in pharmacy includes retail pharmacy, home infusion, hospital, and a little bit of everything. Right now, I'm a clinical staff pharmacist at Baptist. I'm happy here. Baptist is one of the best institutions to work for healthcare-wise, South Florida. And I'm here to participate and to help as much as I can to inform you about, and your audience, about the vaccines that are available, what Baptist is doing to offer the vaccine to the community, and any questions that any of the audience members might have.
Perfect. Thank you.
Thank you, Carlos.
No, thank you. Thank you for that warm introduction as well. And man, it seems like we have a lot of Baptist alums, which is a great thing. So I'd love to take that survey, see how many. Sorry, Jackson over there, Jackson Health Systems, you're a little outnumbered today.
No. I did 15 years at that place over there at Jackson Memorial Hospital. We have a lot of love for Jackson.
Oh, okay,
It's in the blood. I did 14.
yeah. Well, listen, what a segue to you, my friend, which is Dr. Bert Moreno, which is our fearless leader. He is now the chairman of our BASH professional section. Very happy to have him on board. Looking forward to working with him directly. This is a result of that right now. So Dr. Bert Moreno, let us know a little bit about yourself. I'm excited to see what you have to say. Dale, go.
Yeah, I'm Dr. Bert Moreno. I'm a cardiovascular medicine specialist. I do inpatient and outpatient cardiovascular care, and really looking forward to serving with BASH and the alumni to see if we can increase the participation of medical alumni within the Belen community. So if you're a Belen alumni who's in any way, shape, or form involved in medicine, just go onto the Belen website and make sure you log yourself in, give us your information and email and everything, and make sure you make that notification during your registration that you're a medical professional. I think we lost your audio there, Carlos. Can you hear Carlos?
No, he's muted.
Carlos, you're muted, bud, or something happened. Well, anyways, I'll just, since Carlos, we're having a hard time with him, I'll just try to see if we can go forward with what we're going to be doing today. The idea today is we have, a pharmacist, a hospital administrator, and some clinical providers, and to try to give an update in terms of where we are with COVID-19, where we're going, and how we're going to think about treating, preventing, and addressing this massive public health crisis that we've had come upon us over the course of the last year. With that, maybe we could talk a little bit about where we've been clinically on COVID-19. Many of you guys I see were participating before on these AVEs, and we had one right at the beginning where we knew very little. We had another one in July where we kind of started getting a better idea of where we were going. Eddie, where do you see the state of play right now for the medical community in terms of how we're looking at the virus and how we're treating it and our success, and can we be hopeful going forward?
Yeah, no, I think it's actually very amazing where we are today in comparison to where we were just 1 year ago. If we compare this virus to how we managed the AIDS epidemic, my God, we still aren't at a vaccine stage with the AIDS epidemic, and you think about how long it took us to get the ball rolling. So, something that took maybe 20 years to get rolling has been able to be done in 1 year. We have a lot of information. We have a very thorough understanding of who the at-risk populations are. From my field, I'll give a little bit of an update. From the critical care perspective, we have improved our approaches for the management of those patients that do have a bad run with COVID. I think that our mortality is significantly lower for those that get severely ill by early recognition and improving the protocols of care that we have and understanding maybe some of the better therapeutic options that are available. And then we'll talk about a little bit later also, for those that get infected and are high risk, we do have some improvement in therapies with the monoclonal antibodies too that show some significant promise in decreasing mortality. So I think we're in a much better place in terms of understanding. I think we need to get to a better place in terms of diminishing the actual virus out there, and we'll talk about that a little bit more. And that's going to be on the vaccine front, like you guys know, as well as in our behaviors. And I know, Bert, you have a different view also, ambulatory with the cardiovascular patients. I know what your take and what you're seeing is.
Yeah, we get this question all the time is, what's going on with the virus? How are the hospitals? Are they full? Are they packed? And the truth of the matter is that the hospitals have been less packed despite the incidence remaining high, in part because we've been doing a better job in the outpatient setting at getting ahead of the situation with treatments. At first, when people were first getting COVID and people were getting so sick, almost everyone was getting very sick, getting really big inflammatory responses and not really responding well to the limited therapies we had. But we've developed the kind of cocktail that we use to treat different kinds of at-risk patients with COVID. And using these better cocktails, we've had some success, not only keeping patients out of the hospital, but actually improving their outcomes. Willie, I know you're a pharmacist in the inpatient side. What has your experience been with the treatments as things have gone over the course of the last year? And what are you seeing as the treatments that we're using there for the patients with COVID in the hospital?
Yeah, it was kind of interesting ride trying to figure out what would be the best cocktail. I think in the end we ended with Decadron and remdesivir. Remdesivir is antiviral. It's used almost on all of our patients, and right now we are starting to use a bamilibad, a monoclonal antibody, I believe. So that's given in the inpatient setting. Patients come in a short stay setting. They receive their bamilibad. I can't pronounce it correctly. We just call it BAM, B-A-M. And then those patients go home. They get triaged, go home. But those who are showing symptoms of COVID that are severe, like oxygen saturation less than 94, or they're at a risk group, they get admitted to our hospital. Once they're here, we give them, the regimen of the steroids, which is Decadron, and the antiviral, which is remdesivir. Remdesivir, we have a good profile, very few side effects, very few complications or adverse reactions. It's a very simple therapy, 5 days. You start with a loading dose, 200 milligrams, and then 100 milligrams daily. I think we have some great results for our patients. We have good success with our current therapy and current protocols that we have in place here. And right now, what Baptist is offering now is the vaccine. We do have that at the Miami Hilton Dayland location is where we're spearheading our vaccination site. And basically, we're going to vaccinate all of the first-line responders. I know I'm in line to be vaccinated. Once we get the first-line responders, I think we have like a triage list that the CDC has recommended that we follow. And usually it's those who are over 65, those who have a condition in which they are at risk. And then I know right now we're very busy, and I haven't gotten my vaccine yet, but we know that I'm on a waiting list. So I think members of our community will have to be patient and be triaged appropriately for their severity, and then be put on that wait list. I know from other pharmacist friends of mine that it's not available from Walmart, or any of the retailers do not have this vaccine yet. So I think what I can tell the community is that you'll have to go to one of the hospital websites and go ahead and log in and try to make an appointment as soon as possible.
Yeah, so Willie got us into the big topic today. Carlos, are you back with audio yet? Going true, Carlos not back with audio yet. Well, either way, Willie got us into the big topic today, because really we in our other obvious we've been able to speak about treatments and been able to speak about developments. But today we really want to focus in on the vaccine. Willie was talking about how the hospitals have been the primary delivery system up until now for the vaccine. I would just tell the audience that if they'd want to find out where they can get the vaccine, they could also go to miamidade.gov. And there, if you look under COVID-19 vaccine, it'll tell you all the locations where you can get vaccinated. Up until about a week or so ago, the recommendations were for the phase 1A distribution of the vaccine, which was for high-risk people, for example, those in nursing homes and those who were working in hospitals, first responders, healthcare workers. But over the course of the last 10 days or so, I don't know the exact date, they went into phase 1B, which was people who are at high risk, people who were greater than 65 years old. And so I think, the doors are beginning to open for different people other than healthcare workers and nursing home to get the vaccine. And with that, the places where people are going to get vaccinated are going to start shifting to maybe some of the places that you're used to for testing and that kind of stuff. So it's really a state managed issue. Javi, I know you were integral in the process of getting the vaccine going at Jackson Health System. What's the state of play as far as you're concerned in terms of the distribution in the hospitals and how that's going to start to shift to wherever the state decides?
Sure. So I think the biggest issue right now as an administrator, as a hospital that we're dealing with is really an economical issue, an issue of supply and demand. The supply of the vaccine is not there in terms of as it relates to the demand of people that want it. So which is why I think you've seen maybe delays in some hospitals, Jackson specifically, in moving into the other phases that you mentioned before. I know the Baptist Health System is working or should be working in terms of getting high-risk patients that are under 65 vaccinated, but as it relates to Jackson, we're still very much at the 65 and up age. High risk is not being considered. But in terms of the distribution, it's the federal government distributing it down to the states, and then the states distributing it down to those individuals that want to be considered vaccine providers. Initially, there were 5 hospitals in the state. They call it the COVID 5 or whatever it is. Jackson Health System being one that got the initial shipment for the Pfizer vaccine. We worked very closely with, and like I said, this goes not only an economical issue, but also an ethical issue. Who should get the vaccine? Who should be the priority? These are all questions that as administrators, as government, as politicians, you're asking yourself, how do you prioritize the vaccine when you don't have enough supply? So that's I think what you're seeing right now in terms of that. We shared the initial allotment we had with the major hospitals in the hospital system, and I think a week thereafter, some of the hospitals started receiving direct shipments from the state. But I think we're all experiencing the same thing: is that there isn't enough out there for everybody that wants it. So how do you address that issue? And that's something interesting, both an economical and an ethical conversation to have. As it relates to Jackson specifically, we're very stringent. We're trying to get about 2,500 vaccines out a day, or 2,500 individuals vaccinated a day, which is pretty aggressive. We have about 3 locations. And in terms of receiving or having an idea of how many vaccines you're going to be getting, it's up in the air. It's day to day. This is not something that's extremely planned out. It changes day to day. We get a phone call one day, hey, you're going to get a vaccine of an allotment of 15,000, and then you don't hear anything for a couple of days. But the one thing I do want to say is tracking the inventory of vaccines, who is getting the vaccine through Florida Shots, which is a requirement of any institution that wants to be part of the vaccination process. So if an institution wants to become a vaccine provider, they need to apply with the Department of Health. And secondly, they need to have the equipment necessary to hold the vaccine, which is the freezers. That's a little bit on distribution and distribution side. I don't know if I answered the question.
Hey, no, from our end, from the Baptist side, currently as of today.
Hey, Eddie, sorry to interrupt you. Orlandito, see if you can mute your Zoom there.
A cell phone from Willie over there. So we need to.
All right, sorry, Eddie, go ahead, bud.
All right. No, from the Baptist side as of today, we've done 25,000 vaccinations to date. The reality is exactly what you're saying. We're short on supply. I know there's a lot of talk right now in the community and out there about a failure in vaccine distribution, but it really hasn't been in Miami-Dade County on the end of the hospitals providing. I think the hospitals, we have more than enough staff. As a matter of fact, I was actually handing over some of our own staff from home care for vaccination here in the Baptist Health System, but that's not really the shortage. It wasn't there. We currently have, as you mentioned, we're waiting on more vaccine in order to be able to open up more avenues. What's very interesting is that now I think that the state and the government will probably increase the vaccination sites. So it's not just putting the onus on the hospitals. I mean, Jackson, Baptist, Mount Sinai, we're all very busy taking care of the tertiary sides of this disease. Our hospitals are at much higher census, and honestly, I think we look forward to opening up sites outside of hospitals for vaccination of the public. I think like we've already increased, the usage of our staff, and we seek out, as well as Jackson, has sought out additional respiratory therapists, nurses, and different individuals in order to deal with the increase in volume that we're seeing throughout our facilities. So again, we look forward to a better organized process from the state and from the county to open up different vaccination sites. And I think we're seeing that. The Tropical Park site opened up just recently. And that's going to be a pull on existing vaccine availability. So, as manufacturing hands those things out, they'll probably be consumed pretty quickly. What you saw nationally is a stockpile of vaccination. And I thought it was a tremendous approach that we had, which was making the vaccine ahead of time, even though we hadn't gone through the phase 1, 2, 3 trials. They finished the trials appropriately, all timed at the same time. So the studies for these vaccines were completed, and it's one of the largest vaccination trials ever done. To be honest with you, the way it's been done has been correct. It was structured in a way to all be done at the same time. And then the vaccines were available, and they kind of blew their whole amount of vaccines. They handed that out, and now the onus is on the manufacturing and to be able to re-up the hospitals and re-up the facilities, and that's where we're at currently. I don't think there's been a distribution issue here in Miami-Dade County in terms of getting up and running. I think really it's just been now the key process, the key rate limiting step is probably going to be the manufacturing and the re-upping of the vaccines for our individual facilities. And yes, you mentioned the at-risk populations are being addressed, and I want to mention that includes obese and diabetic individuals. So it's not only above 65 people. Bert has a lot of patients with cardiovascular disease also, that have increased risk. So, the facet, and you're right, that category is extended past the healthcare providers and the nursing homes out into that at-risk group of individuals. And in the meantime, we need to continue to operate in a fashion where we diminish the risk of infection to each other in order to be able to get everybody vaccinated and hopefully reach herd immunity with a vaccine instead of with an ever-changing higher risk virus.
So we've got these mechanisms where the virus is getting distributed, and obviously the easiest place to distribute a virus at the beginning was the hospital systems. They distributed all kinds of vaccinations to their staff, et cetera, and now the state's going to move on to other areas and people applying for it. Willie, I just wanted to loop you in here, and because we're talking about distribution of the vaccine, but what are you telling as a pharmacist your friends and family when they ask you the question that I've gotten a bunch of times, which is, should I actually even take the vaccine?
He's muted. He should be unmuting himself in a second because we had some audio issues. So he's muted right now. So maybe have somebody else take it and he'll jump in as soon as he can.
Bert, I'd like to just jump in on something. Eddie, I mean, we're talking about supply, and I also wanted to mention that it's not only the vaccines that are short in supply. Hopefully Willie can talk about it too, but there's special syringes that are required for these vaccines that the state also provides, and those are also in shortage. So we have two issues affecting supply of the vaccine to the community. Not only the actual vaccine, but the syringes that provide the vaccine to the individual. So I wanted to touch up on that as well.
And I want to mention also, and we said it a little earlier before we let everybody on, Jackson was principal on receiving the initial vaccine with Pfizer, and they shared that with the hospitals. And I thought it was a phenomenal approach, ethically to balance out and try to get the first line healthcare providers taken care of. A lot of us have take care of elderly people at home or have different individuals that we care for, and we didn't want to bring that that virus from the hospital back to our families. And I really appreciate that approach of taking care of those individuals. It decreases absenteeism at a time that we need a lot of providers available to us, and that was a phenomenal approach. Now we've received that Moderna vaccine, and hopefully, Willie works within our system. We can talk a little bit about that. I think the Moderna vaccine has been a little bit easier in terms of management to take care of than that Pfizer vaccine. The initial Pfizer vaccine was a little bit more difficult to manage because of issues with more issues with maintaining temperature and transporting. And we look forward to now that Johnson & Johnson hopefully is gonna have a vaccine out too. Although I hear there's a lot of manufacturing issues there also, in terms of being able to have volume available for that. Bert, I think you and I both vaccinated. You already took your second dose also, or?
Yeah, I had a great vaccination experience. I had a little bit of muscle soreness on my left arm, and for the second one, I had a pretty strong muscle aches throughout my body. Yesterday, I took a rapid test, those rapid, almost pregnancy-like looking tests, and I had a really strong IgG line on that. So it looks like the vaccine was very effective in me. I took my second shot 8 or 9 days ago. And so I have a massive antibody response. It was pretty obvious. It was one of those you're pregnant right away results.
Yeah. So
we have Willie back
with everybody. I wanted them to hear about the vaccination experience a little bit, since I know you and I have gone through it, and it's variable. You need one of the things I recommend is that these vaccines are a little reactogenic. So I do recommend that you have the day after the vaccine off from work. Don't plan on a full schedule, because you might feel aches, pains, the usual things, a little soreness at the injection site. I think that's very fair, and that's probably most of the people are going to feel that soreness at the injection site, maybe a little more so the second time around. Maybe some body aches, maybe, maybe a few of us, I did have one of those reactions where I had a little bit of fever, throughout the day, and with the chills and the whole thing, but knowing very well that this is just a vaccine, I'll be fine by the next day. And I was, actually by the following evening, it had all passed and I was back to normal. So, but again, just be prepared. You could have a little bit more of a reactive experience, or some of the individuals, the older individuals, generally a little bit of ache in their arm and nothing much more after that either. So it's variable. Some lymph nodes under your arm, it could be swollen, and that's great. All these things are basically your body making antibodies, which we expect and we want. So perhaps some of that reactogenicity and some of that response, like Bert said, it's really good news that your body has a great immune response and can make a ton of antibody and protect you, from this virus. So I did it with a smile, took my lumps, took a couple Advil, and I was kind of happy at the end, and I'll do it again in a heartbeat, because I feel that I'm protected. Like Bert said, I don't even need that antibody stripe that you did. I'm 100% sure that I have a load of antibody after the lymph nodes were swollen and whatnot. It's something that you feel confident that you're taking care of. And in terms of mortality, no mortality for the group that's vaccinated right now from what we've seen. You could potentially still get the virus, but you're not going to die from it. And that's a huge thing for all.
Yeah, so one of the questions I get all the time is Moderna or Pfizer, which one should I take? Should I have a preference? Just to be very clear about that, the studies were almost identical in terms of the number of patients studied. They were in the 30,000 patient range. The results were very similar in terms of them being 95% effective at preventing symptomatic COVID-19. So obviously, there was a really good response with both, and I don't think there should be any preference really. Secondarily, I think we've got that's a lot to look at. I think we got I don't know, something happened where I lost everything here. Willie, are you back in there? I wanted to see if we could loop you in here with a question about whether or not, how you're recommending to your family and whether or not they should get vaccinated. How confident do you feel in the data, and are you comfortable telling your friends and family, go out there and get this vaccine? Okay, I don't think we have Willie. One of the things I wanted to do, and maybe Eddie, you could help me out with this, is I wanted to make sure people kind of understood how this vaccine works. So this is an mRNA vaccine, and essentially what it's doing is it's allowing for a programming mechanism to create an antigen in your blood. And so when you hear about antibodies, antibodies are what your body creates to fight off antigens. And I'm sure a lot of people, when hearing about this vaccine, have heard about the spike protein. The spike protein is essentially the key that actual COVID-19 uses to get in the cells. And what this vaccine is doing is it's creating the key without the virus, so that your body can identify it, make a lot of antibodies against this key, so that if the virus comes into your bloodstream, you have the antibodies, you have the ability to attack these keys and not allow the virus to get inside your cells, replicate, and become a big process. What do you think? This is it's an interesting thing because this is actually one of the first mRNA vaccines that we have at our disposal. How do you feel about so far the safety data as it relates to this vaccine, and what are you telling your friends and family who have concerns being the quote unquote guinea pigs of this kind of vaccine?
Let Willie answer. I think he's gone. Willie, you there?
Perfect. Thank you. Yes, can you guys hear me?
Yeah, we got you.
Can you guys hear me?
Yeah.
Perfect. Okay, so I'm glad you asked that question because, China was the first to come out with their vaccine, but they're actually using a dead or attenuated virus. The Americans, or Pfizer and Moderna, we're using a monoclonal technology, which is fantastic. It's been around for many, many years, and we use it in our oncology sector. So what they do with the monoclonal antibodies or vaccine is that they use a piece of the RNA from the virus, and they code it so that it's given to you. You inject it as a vaccine, and your body is going to recognize that piece of the virus. So in this case, it could be one of 24 proteins of the COVID virus. So this product is a much safer alternative than what's being offered worldwide. What we are receiving is just a portion of the virus. We are not receiving a live virus. So that's important because sometimes you will get, if you wish to get something that's not monoclonal, maybe something from another country, their viruses are, they're killed or they're denatured, but they still have the ability to provide or give COVID. The one that's offered by Pfizer and Moderna, you cannot get COVID because you're not receiving a COVID virus. You're receiving a part of it. So the safety profile is excellent. I highly recommend it to everyone. The research and technology has been around for a very long time. I first was hesitant. I first wanted, to make sure that my colleagues got the vaccine first, and they did. They were the guinea pigs. And so far, it seems that all that they were complaining about was soreness of the, at the side, injection side, maybe a little bit fatigue. And you can expect that with the second dose, by the way. So if you have, you can tell the community that the second dose is the one that's going to offer you the most adverse reaction. But the safety profile is superb and way, way better than a normal virus would be. It's a great product. It's a great technology is being used. And I think it's fantastic that they were able to use it and create it so quickly for our market. And I absolutely do promote it. And I do think it's absolutely safe for everyone,
Willie,
except, of course, there's some limitations.
You bring up something that I want to piggyback on, So a lot of people are asking me, most people are getting through this virus and they're, they either asymptomatic or, barely have symptoms, just lose my taste and I was fine afterwards. Most younger people will tell me that. But I wanna bring out something serious here, which is in the world of cancer, 20% of all our existing cancer is induced by viruses. We're not even aware of what the side effects and long-term ramifications of this virus is going to be on those that have been infected, even the ones that have had it mildly. Anytime you get a virus introducing, and this is an RNA virus, not a DNA virus, but there's other RNA viruses that cause cancer, like hepatitis C, for instance. So when you have RNA viruses, they're introducing a world of genomics into our cells. And they're also changing the way our cells express themselves. And they can turn on certain oncogenes that can cause long-term ramifications. So this virus itself is extremely dangerous. We don't know what the long-term ramifications of this virus is going to be in our population and those who have been infected, and what it means for them 20 years down the line or 15 years down the line if it's turned on different processes. So this is a very dangerous virus. The vaccine, although yes, can be reactogenic, and yes, you can have a couple side effects and feel a little bit bad for a day, is not the virus. What that vaccine has given us is just a little piece of nucleic acid, a messenger RNA that's coming into our cells and is making a little piece of the spike protein that Bert said. That's all it's doing. You're going to get a little bit of immune response because we need those cells then that are now making the spike protein. Your own cells are being hijacked to make a little of the spike protein and express it on their surfaces. And this is a novel way to give a vaccine, like you mentioned, Willie. This is phenomenal because the way that your cells are expressing this, as opposed to the old vaccine where they just gave you a piece of the virus, your cells are now expressing this, and this is inducing a very usual immune response, like if you had been infected by something. And the way that those little pieces of protein are being presented to you are inducing a phenomenal response. And that's why we got this 95% effective virus with both, effective vaccine with both of these COVID vaccines. The mRNA vaccines are the future. And on top of that, they're very easy to readjust. So all the old vaccines, it took forever on cell culture to regrow these pieces. Anytime, if this virus were to mutate, it would take us only about 6 weeks to change the vaccine and get it right. So we can keep up with it. This has changed the world in terms of how we vaccinate going forward, and also how effective these vaccines are. So I'm super excited. I was very happy to be the early guinea pig, you know, in taking it. I have a lot of faith in what we're doing, in what we're giving to our patients, and it's gonna be the killer of this virus. So it's just a matter of time. We got to get our distribution right and the other components, but the vaccine is spot on, and the Americans have the best vaccine. There's no doubt. This Moderna vaccine and Pfizer vaccine that we have here in the country is the top-notch one. There'll be other things that come out, and because of other risk factors to certain patients, perhaps other patients will receive different vaccines just because of the risk, the profiles. There's a high allergic issue with some patients with this vaccination, and it's only really patients that have been allergic to vaccines before, not because you're allergic to peanuts or you're allergic to shrimp. It's people who are allergic to vaccines or vaccine components that we have to be very careful with in terms of vaccination. And those individuals may get a different vaccine because they may have different vaccine components that they're not allergic to. So that there may be reasons to not get these mRNA vaccines for a very tiny subsegment of the population. And we're getting very intelligent in our administration and identifying those individuals and keeping them from it at this time.
Yes,
Eddie,
just to put
Wait, can you guys hear me now? Hello?
Yeah, got you.
Yeah, Carlos, we got you.
I guess.
Just to put a loop
I'm back.
on this issue of the safety of the medicine of the vaccine.
Go ahead, Bert.
Yeah, just to put finish up this conversation. The mRNA that's injected into you is actually thrown away by your cells. The spike proteins that are created that create the antibodies, those same antibodies that you're creating are going to attack the spike proteins that you've created, and they're going to get rid of the spike proteins. So the normal process of the vaccine is that the actual vaccine is destroyed. The spike proteins that are created are destroyed. And by the time your immune system finishes with those two processes, you'll have memory in your cells on the virus. And that's what you're doing. You're creating a memory of the virus so that if it comes up, you identify it and you take it out. But the things that we're injecting in on this vaccine are actually all going to be gone from your system within a certain amount of time. Someone asked on the chat, should you be concerned if you do not have a response to the vaccine? I'll just go ahead and answer that real quickly. The percentage of people who had strong responses to the vaccine were in single digits on the study, something in the range of 6%, 1%, 2%, depending on the severity. And so if you don't have a strong response, I don't think you should be concerned. The effectiveness of the vaccine as studied was 95%. And that didn't mean that it was 95% of people who had a response to the vaccine. It was 95% of all comers. And so if you haven't had a response, I think you should feel comfortable.
Let me take you back on that, Bert, just to make sure that everybody understands. So your body is seeing this messenger RNA is coming in. You're making the spike protein. The messenger RNA gets used. It's gone. You're not left with any of that messenger RNA. The spike protein is being shown on your own cells. They're finally attacked by the antibodies you make. Those are gotten rid of also, like Bert said. The reaction that people have that's variable is not that the antibody is going to come in. You made the antibody, you got your immunity. The reaction that, for instance, that I had fever and Bert didn't have fever, he just had soreness, that's our individual host immune response. That doesn't have anything to do with how much antibody you made. So I agree with you wholeheartedly. We're actually starting to study that now. Is there a difference between my response and Bert's response and the amount of antibody? I think, Bert, you answered that. You have a high titer strip of antibody, right? So you have a ton of antibody after your vaccine. So that's really just our individual immune systems and how they overreact or underreact. But it's not how much antibody you made. The antibodies and the memory cells that you'll put out there that make that antibody, those are yours. And don't be nervous if you felt great after the vaccine. Most people do. They just felt a little soreness and they moved on. you may have more antibody than I do, even though I had fever and I felt a little crappy for a day. So don't worry about that.
Bert and Eddie, I actually have a question for both of you. So the only real adverse reaction that I've heard of and sort of turned people away is there was a doctor at Mount Sinai who had a reaction and passed away as relates to the vaccine. Can you explain a little bit what happened there, just so that the general public has an idea what happened there?
So what happens with vaccination, I think, is an issue is that obviously we're vaccinating now. We're in the millions in terms of vaccinations given, right? So at the point that we're in the millions of vaccinations given, the chances now that just a random presentation of any illness occurs within the 2 or 3 weeks or month that you got the vaccine, and that it gets blamed on the vaccine is really high. I mean, at the end of this, we're going to vaccinate 60% of the American public. We're still having all our regular diseases that present, in this case, it was ITP, which is low platelets, and so autoantibodies to platelets. So, possibly, his immune system got a little bit turned on with the vaccine, and it may have unleashed something that he may already have been programmed to get. I can't tell you the answer because it's too early, but in giving millions of vaccines, the cases of ITP that we've seen haven't been a statistical spike yet above normal. So I can't tell you that it was necessarily related to the vaccine yet. But are we going to be vigilant if a few people get ITP, within 1 in a million, or at that point, or a couple of million? We're going to be vigilant. That's the second phase of vaccination. So the initial studies on these vaccines were done on about 33,000 people on one of them, 20-something thousand people on the other one, and then really now is the big phase, and that's why I was happy, and Bert was happy that we went ahead and vaccinated our healthcare population first, because we're working. We're a little bit younger, we're capable of sustaining something. And then we vaccinated that group. And in vaccinating that group, we found out, this is safe. What we're seeing, we've vaccinated now, like I said, well over a few million people have been vaccinated nationwide. And what we're seeing now, like you said, is maybe a case here, a case there. But you know what? Within a few million people, if you had taken a placebo group that didn't get the vaccine, you'd probably get a case of ITP here and a case of something there too. So things are going to come up. People by association are going to try to blame it on the vaccine. But as long as statistically that doesn't differ from the usual incidence of those diseases in the population, then we move on. And at the end, the mortality of the virus, 500,000 is what we're looking at coming up soon. So, by a few months from now. So when it comes to that, one case of ITP and a death, even if it were from the vaccine, I'm sorry, versus 500,000 deaths, from a virus, I don't think that the scale is even close in weight. But I can't even tell you that it was from the vaccine.
All right. Wait, can you guys hear me now?
Yeah, and you're spot on.
All right, perfect. Wait, so Bert, if you don't mind, I have a couple questions here that I want to ask. That's from the chat. I know you have it too. This says, here's a question for Willie. I don't know if he can answer this, but it says, I made appointments for my in-laws at Baptist. Today we received notification that their appointments were canceled. They are both over 65. Can you explain why that is? Any response that anybody can help chime in on that?
Yeah, if Willie can't answer, I can answer.
I can't answer that for Baptist, but there, like I said, there is a supply issue in the United States in general and in Miami-Dade County. And what's very important here also to consider is that you need to account for not only the first vaccine but the second vaccine. So if they don't have enough vaccines for the second round of folks or the round of folks need to get the second round, they might need to utilize those vaccines for that group. As it relates for anybody in the community that's trying to get the vaccine, the Jackson Health System, if you guys have Instagram updates when they're going to be opening up appointments. So I suggest that you follow Instagram so that you have first notice on when the appointments are opening, and you can go ahead and log in and make your appointment.
So currently at Baptist, to answer the specific question on the cancellation, we have all our second doses for everybody that we've vaccinated with the first dose. So everybody that's had a first dose will get their second dose. We have those available for them. But as Javier said, the vaccination quantities that we've received, the vaccine quantities that we received, we can't promise everybody that we've scheduled right now, because we were made promises to receive a certain amount of vaccine and it's not yet available to us. So at this moment, we had to cancel out certain appointments that, where we knew that we currently couldn't promise that we had that content with us. So from our end, on Baptist, we're up to speed with vaccinating everybody that we have vaccine for. The issue is we're waiting on vaccine. So at that time, we didn't want people showing up and not have that dose for them. And we definitely don't want to give somebody second dose to somebody else and then having them show up for a second dose, because there's a lot of individuals that require that second dose and we can't yet tell who they are. So that's something that you'll see in the UK. They're moving to not give the second dose until they give the first dose to everybody. That does not follow the literature or the science. The EUA on the drug, the emergency use authorization, was for 2 doses. And the way we're following this is if we gave you your first dose, we're securing that you have your second dose because we're looking into protecting those individuals. So we are still putting people in, but we moved back to the original criteria, which is trying to finish off with the healthcare workers and some of the other high-risk populations before we move back to the over 65 group when we know we have secure product.
All right. Thanks for that answer. I got another question here that I want to ask. I don't know if it was asked when I slipped away. I tested positive for COVID on December 26th with no symptoms. The week after, I had some fever, and they gave me the BAM at Doctor's Hospital. I'm still testing positive. Do I keep testing until I get negative like every week? Also, understand that I have to wait 90 days for the vaccine. Any response to that?
Yeah, so
go ahead, Bert.
Yeah, no problem. So essentially he's asking, do I quarantine, right? Because this is why he wants to get tested. He wants to know if he can enter the world. And the current recommendations on testing are that you can enter the world if you've gone 10 days after having some sort of symptom. If you want to do it faster, you can get tested. But if you've had no symptom for 10 days, essentially, there's no real recommendation that you have to be quarantining. In terms of the treatments, and maybe I don't know where he got his treatment, but essentially what he's referring to as the BAM is an infusion of antibodies. And so you don't want to have the vaccine placed when you already have an infusion of antibodies because you won't generate the antibody response. So he's correct.
So technically, I'll answer that again, because technically, you could have a vaccine within 30 days. We're not giving vaccine within 90 days. So if you've had the virus and
no, he was asking about his treatment.
The BAM, the BAM and vaccination after BAM. So we're not vaccinating after BAM for 90 days. The reason for that is you already have immunity. Currently, your immunity is at least good for 90 days, just as anybody else that's vaccinated. So you kind of drop a little bit to the back of the line because you're protected. To the same extent as other individuals receiving the vaccine. But it's not really horrible if you end up with a vaccine 30 days after BAM. The BAM is not going to mess up your vaccination necessarily. But the rules are exactly as you said. We're going to wait 90 days to vaccinate. The inverse, though, if you've received the vaccine and you get COVID, because some people can't get COVID after vaccination, there's still a candidate for that, right? So you can get the Niberto. To date, we've done, I'd say somewhere in the 1,400, maybe 1,500 doses of bamlanivimab at Baptist. We're very proud. We've run a pretty good show this far. As soon as the EUA came out, we've been infusing all high-risk individuals. I've infused some of you Belen guys also, that have called me, and we've arranged that. Basically through our urgent cares, you get seen, we can transfer you there. If you have a positive test and you come to our EDs with high risk, we will try to get you infused, but we're trying to move the process to our infusion centers. So we're using our infusion centers away from our EDs for the bamlanivimab. For those that are not familiar with the product that Bert was mentioning, it's a monoclonal antibody. It's very similar to the Regeneron that President Trump received. I think it's better that the data on the bamlanivimab, although it's 1 versus 2 antibodies, is better than the Regeneron data. The number needed to treat is approximately 9 to 14, depending on your risk groups. On a high risk group, number needed to treat, meaning for every 9 people that we give that show up symptomatic, high risk for getting worse from COVID, for every 9 we treat, we avoid 1 of them moving towards severe hospitalization. The reason that sounds low, is because most of them don't move to severe COVID and hospitalization. So the actual something called, for the nerds like me out there, the relative risk reduction is actually 80%, which means that for, in a comparison, if only 10% of those high-risk people would have ended up in a hospital or an ED because of COVID, we actually got that number with the bamlanivimab given timely down to 2%. So it really reduces your risk relatively 80% of needing a hospital. And it may be one of the reasons why we're declining in our mortality and in our hospitalizations despite such a high incidence. If we gave it to 1,300 people, and basically that number needed to treat being in the 9 to 14 range, we potentially have like 120 severe hospitalizations avoided at this point. And I'm really excited about that. I'm more excited about getting vaccines and avoiding the whole thing in the first place.
All right. Well, I have an interesting question here as well. It should be quick. Is second dose more of a quantity that you receive than the first dose? Why do you feel more side effects on the second dose?
Is Willie there to answer that? I think that's a good question.
Yeah, that's Willie.
He's muted right now. Willie, if you can unmute yourself.
Hi, Carlos, can you hear me?
Yes, go ahead. Did you
Hi,
hear the
Carlos,
question?
can you hear me? Yes, that's absolutely true. So the sources claim that the second dose is the one that's going to give the most side effects. Usually the headaches and the fever, the muscle pain, the fatigue, and that's usually going to last like 2 days after that. But it is in the literature that the second dose, especially older patients, are going to tend to have older patients tend to have less of a reaction than the younger subjects. The reactions for the second dose is coughing, shortness of breath, runny nose, sore throat, loss of taste and smell. I'm sorry, these are not the common side effects. So the second dose is the one with the most reactive symptoms than the first. It's absolutely true.
And Willie, you correct me if I'm wrong, but I think once you've had the first dose, you do develop an immune response within 7 to 10 days already. There's been some data coming out that you start to begin to have protection, and obviously if you have an immune response developed from the first dose, once you get exposed on the second one, maybe you would have a stronger response to what's being injected. Is that correct?
Yes, that's correct. It seems that when they do the COVID diagnostic test, you're going to get a spike in the protein, the IgM, Ig, after the vaccine. It's absolutely correct.
So that booster dose was what comes and just makes sure that you're going to make again a second spike of antibodies and really take it home on the memory cells. So it ensures the long response. So the first response to the vaccine puts out some antibody which protects you. The second one is the reason for that second one is to induce a longer response. Of course, the vaccine's not been around that long, so I can't tell you how long it is because we haven't studied anybody outside of 5 to 6 months at this point, right? But we're really hoping that this is going to be a couple of years or more in terms of the response. And that's why we're really pushing that second dose. Does it stink if you get some symptoms like I did? Yeah, man, you feel bad. But man, I'm really happy knowing that I got that long memory response coming forward, because I got to deal with these, with this disease in the ICU, day after day. So I want to make sure I'm protected.
Good point. Wait, I have another question here. It was mentioned that Moderna and Pfizer vaccines are essentially brand new science, made with only part of the virus and everything. Do we foresee this to be a one-time vaccination, or will this be a yearly flu vaccination like other flu vaccines?
If we get it right, we'll be done with it, on this vaccine. So when it comes down to it, if we can get a herd immunity where the virus dies out, we're done with it. This is an RNA virus. It does mutate. So we have mutations. I don't want you guys to be scared out there. You're gonna hear every day. There's the South Africa mutation. There's this mutation, that mutation, the UK variant, they'll call them the variants. There's the RNA viruses by nature are going to change, certain sequences and change an amino acid or two. As long as the vaccine antibodies continue to recognize a significant amount of that virus, we're good. If we give this long enough, and really slow at the whole vaccination side, even a slowly mutating RNA virus will eventually mutate away from the existing vaccine's protection, in which case we'd have to alter the vaccine. Does that mean that the vaccine no longer works? No, it just might decrease the efficacy of the vaccine slightly. So in terms of being 95%, if you start dinging and changing amino acids on that spike protein, it might drop to 90 or 85. Does 85 mean that 15% of the people can die of it? Not necessarily. It just means that you're still going to make some antibodies to a significant amount of that spike protein, but you might become a little bit more symptomatic as opposed to be completely asymptomatic, with your exposure to that virus. But yes, the longer it takes to vaccinate everybody in an RNA virus that mutates, eventually it will start evading the vaccine's provided immunity to the patient. So there is a race here, and you can't really wait around. I'm just going to wait 6 months or a year to get vaccinated. No, this is the duty that we have towards each other, because this vaccine's not really about protecting myself. It's about creating a herd immunity so we can get rid of this virus.
All right. Well, thank you.
Eddie,
guys, we have to start wrapping it up.
Carlos, Javier had a question there.
Yeah, it's actually a question.
Go ahead and ask
question for Eddie is just curious. We have to get as many people vaccinated.
Go.
But do you think that it should be mandated that everybody gets the vaccine?
Okay.
What are your thoughts on that?
And now we're talking philosophy, sir. So we're talking something else. So we could start with one thing. So we mandate flu vaccine for our employees in our hospitals, and that's to protect not only ourselves when we're at work, but to protect our patients from ourselves. We're providing a service. We don't want you to show up at a hospital. We don't want to be the ones giving you the flu. And that's fine. I think the flu vaccine has a long history and track record. Currently, we're under something called an EUA. An EUA means an emergency use authorization. So we don't have necessarily full FDA approval on this product, meaning that it's still under investigation. Basically, Bert, me, a few of our early group is still part of that group that we're now getting millions of people vaccinated to find out what the risks are long-term. Things like you asked about that ITP case, is it related? Is it not? Because of that, I think ethically, we should never mandate our employees to vaccinate at this time frame. What you can do, which many people are, and since you're working at Jackson and we're here at Baptist, you may be able to incentivize your employees to take it financially or different ways in order to achieve that herd within your workforce. But I think until we establish a long-term profile on this, it'd be a little tough to mandate. And definitely to mandate for society, I think that comes at a much greater cost to our freedoms than anything else. So but that's personal politics. So that's an unfair question, an unfair answer.
But I think just from that perspective as well, there's all sorts of things that are mandated on our personal freedoms. We are not used to having mandates in terms of our health. It's a very private thing. But those are things that'll be litigated in the political process, and hopefully we've been able to help everyone here who's on the Zoom meeting, and everyone who watches it on YouTube understand a little bit better about the vaccine, its safety, and where we're going with COVID.
Yeah.
There was one more question. There was one more question that it's what happens if you don't or can get the second dose within the recommended time frame. That was the only one we missed.
Oh, okay, perfect. Thanks, Pep.
I think you really need to try, right? So what has been studied is what you want to do when you take any medical therapy is take it in the manner which has been studied, because it's in that fashion that you have the 95% efficacy. If you vary from the protocol that was studied, the results of the study will be less applicable, and you'll feel less confident that you'll get that positive result. And so I can't imagine an instance in which you wouldn't get the second dose. You need to get the second dose if you get the first one, unless you've had some massive response. And so obviously in that case, you discuss it with your physician. But I don't think there's any instances in which you have the first dose and then there's no second dose available. All the people who are all the entities who are distributing the virus at this time are doing so keeping in mind what they have to keep in the back burner for the second one. And so while it's an interesting question, it's not one that you should come up, that should affect you in any way, shape, or form. Get your second dose if you get the first one, because that's how it was studied and that's how you can be assured that you'll get the benefit.
There are increased infections in people that haven't finished their dosing compared to those that have finished their dosing. We know that already. So we've seen a lot of people come in with COVID a week after the first shot, 2 weeks after the first shot. You don't have immunity to the point, as Bert said, that the trial showed the data for. And even, a day after the second shot, I've seen a couple of infections come in. I haven't yet, I'm not seeing anything after in our group, the group that's had the second shot. It's now a couple of weeks out from there. At that point, you really established immunity. In the trial data was there. Unfortunately, the trial data included a lot of early infection where people really didn't have immunity. Said, oh, look, it's 95% effective. But in that 5% group, a lot of them weren't even finished with their vaccination series, really, to the point where they should have been fully immunized. So maybe it's even more than 95% effective. And you're going to see a lot of argument with a lot of other vaccines in the trials about efficacy because they include groups that weren't really fully immunized. So follow what the protocol is, as Bert said. You need it. A lot of us need that protection.
All right. Well, boys, with that said, any final thoughts? Willie, if you can hear me and you can get on and you want to say something, I know you were having technical difficulties. Going once, going twice. All right. Well, I want to thank Willie as well, but we'll thank everybody after. What about Javi? You want to say some final thoughts before we close out to the people out there and with what anything you want to say?
Yeah, the only thing is I want to say I encourage all of you to get the vaccines. If you are interested in getting the vaccine, at least from the Jackson Health System, you can get an appointment through our website when they become available, and you can also get information on the miami-dade.gov website, which Bert mentioned earlier, in terms of all the testing sites that are located in Miami-Dade County. What you will see is that some institutions are working differently in terms of who can get the vaccine. Jackson is specific to 65 and older, and its employees and healthcare workers, whereas Baptist, I know, is now taking some of those at risk that aren't 65 just yet. So there are differences between hospitals and institutions, but I encourage everybody to get the vaccine.
Bert, last comments?
Yeah, let's go eat.
Eddie, you good. Well, listen, a couple of things. We do have an amazing PowerPoint that was put together by Willie Braceras that we will be posting on our Be Connected website. We can also send it to all the participants that were here today. A lot of questions there, answers. I'll get permission from him and see if it's okay if I can share it with you guys. But it was phenomenal things. I want to thank you guys, the panel. This was extremely informative. I myself got a bunch of information because I had a relative that got sick after his second shot. He was a nurse. Well, he's a nurse, and he also got sick. But I got a lot of those questions answered, which I got to go back to my wife and let her know. Anyways, want to let you know, so stay tuned to our next 2 AVEs. We have one coming on January 28th, real estate investments with an amazing panel there as well with Derek Verona sponsoring from the Acres Group. And then we have our AVE on February 18th, sponsored by SAFE, and that's going to be on the on Bitcoin, on cryptocurrency. That sounds very interesting. We were talking about it before we got on the show. So to everybody, thank you to Jose Lopez Varela, my wingman in the back. Nobody knows he's not even seen. So thank you, Bert, again for putting us together. Eddie, Willie, Javi, for your insight. And guys, stay tuned for our next AVEs. And thank you for joining. And this will be posted on our YouTube channel. Please go on and sign up to our YouTube channel. We have all our AVEs over there. So it's all great stuff.